Welcome to the deep dive. Today we're tackling something that often sidelines really promising young athletes. Is frequently just brushed off as, oh, growing pains. But what if the real issue isn't just overuse? What if it's actually about a surprising weakness built right into growing bones? A weakness making a key part of their skeleton maybe 2 to 5 times less resilient than everything around it. That core idea is really central to understanding iliac apophysitis. And honestly, it changes how we should think about treating it. So yeah, we're diving deep into iliac apophysitis today. It's basically an overuse injury, involves inflammation of something called an apophysis. And it's particularly common in athletes, whose skeletons haven't finished maturing yet. We'll be zoning in on a few specific spots where it tends to pop up. The iliac crest, that's sort of the top edge of the hip bone. Also the anterior superior iliac spine, we usually just say AIS. And the anterior inferior iliac spine, or AIIIS. Our mission here is simple: peel back the layers on this injury, understand not just what it is, but the surprising why behind it. And crucially, map out a clear path for athletes, for families, from feeling confused to, hopefully, a confident recovery. Think of this as your guide, really getting to the bottom of this often misunderstood condition.
Yeah, and the real breakthrough, I think, in understanding this is realizing it's not just overuse in the way we normally think about it. The main culprit is this fascinating biological vulnerability. It's the physioplate, basically, the growth plate in young bones. It turns out it's actually, like you said, 2 to 5 times weaker than the ligaments and tendons around it. So this inherent fragility is really the primary driver, especially when you combine it with rapid growth spurts. Plus, other factors like genetics, maybe some anatomical variations, and these repetitive microavulsion injuries, those are like tiny, tiny pulls where the tendon just keeps tugging on that vulnerable bone attachment site.
Wow. Okay. So it's not just about pushing kids too hard, but it's built into the way their bodies are developing at that stage. And that fundamentally changes how I think about growing pains.
Totally. Which makes me wonder, how tricky is it then to actually pinpoint this specific condition? I mean, it probably feels like other common aches, right? For any parent listening, getting a clear diagnosis, well, it can feel like navigating a maze sometimes. That's a really crucial point. Diagnosis, it really starts with a thorough clinical evaluation. A detailed history is absolutely vital. You need to understand any specific mechanism of injury, how it started, and, importantly, rule out other things that might present in a similar way. Then, when we do the physical exam, the focus is really on pinpointing pain, maybe some swelling, tenderness, right at those specific tendon attachment spots we mentioned earlier.
Right. And when it comes to actually seeing what's going on inside imaging, what's the role there? Are standard x-rays usually enough?
Well, radiographic imaging, like your standard hip and pelvic x-rays, that's our first step, first-line modality. They're helpful, definitely helpful for differentiating apophysitis from, say, an actual apophyseal fracture, which is, more serious.
Yeah.
But it's really important for parents, coaches, everyone to understand. X-rays are often completely normal in cases of just pure apophysitis. CT scans, actually less reliable here. They might even miss the diagnosis altogether. What's really sensitive, what lets us see the finer details, is an MRI. An MRI can show subtle things like bone marrow edema swelling inside the bone, or maybe slight enlargement of the physis, the growth plate. Ultrasound can also be pretty useful. It might show a widened or fragmented apophysis. And the great thing about ultrasound is you can easily compare it to the other unaffected side. Plus, it helps us look for any related muscle or tendon issues nearby.
Okay, that's incredibly helpful for actually visualizing it. You mentioned how specific activities relate to these sites, but what about kids who play multiple sports? Does that just muddy the waters for diagnosis, or do you still typically see, dominant patterns?
Wow, that's a great question. And yes, it can certainly make the clinical picture a bit more complex, no doubt. But even with multiple sports, we often find that the highest impact activities, or the most repetitive ones, they still tend to point us towards the specific site involved. Maybe we should break down those specific areas, because each one does have its own sort of typical timeline, and the activities usually linked to it.
Yeah, let's do that.
Okay. So, for instance, iliac crest apophysitis, the knob edge, that typically shows up around age 13. In girls, the bone there starts to fuse, or ossify. That means the cartilage turns into hard bone around 14. For boys, it's a bit later, maybe 15 to 16. And that ossification process, it progresses from the front outer part towards the back inner part. This type, the iliac crest one, it's common in sports with repetitive strain or impact. Think rugby, hockey, tennis, also dance, running. Pain here can often be brought on by movements like sit-ups or crunches. That's because of the abdominal muscles attaching right there. I actually remember a case of a young ballerina, maybe 13, came in with hip pain. Her rehearsal schedule had just ramped up significantly. Initially, her parent thought, oh, it's just muscle soreness. But the very localized tenderness, right on the crest, plus the timing with her growth spurt, it strongly suggested iliac crest apophysitis. It really highlighted how even activities we might think of as lower impact, like dance, if they're repetitive during that vulnerable growth phase, can trigger it.
Huh. Fascinating. Dance too, not just the high contact stuff. Okay, so that's the top rim of the hip bone. What about moving down slightly to the ASIS, the anterior superior iliac spine? How does that one usually present?
Right, the ASIS. That usually appears a bit later, maybe between 13 to 15 years old. But interestingly, it fuses much, much later. Typically not until around 21 to 25 years old. This one often happens from a sudden, forceful contraction of specific muscles, the sartorius or the tensor fasciae latae. Think activities like sprinting or maybe a powerful kicking motion. If you're looking for signs during an exam, trying to flex the hip and rotate it outwards often aggravates the pain because that engages the sartorius muscle.
Okay, got it. And the third common spot, the AIS, anterior inferior iliac spine.
The AIS. Yes, that one also tends to appear around ages 13 to 15. It fuses earlier, though, usually by 16 to 18. This is typically caused by a forceful contraction of the rectus femoris muscle. That's one of the main quad muscles. It's especially common during kicking actions, football, soccer. Clinically, it might even look a bit like a hip flexor strain. The pain is usually worse with hip flexion, sometimes particularly when the knee is also extended.
Okay, so we've got these distinct locations, the activities often involved. What about the overarching symptoms, like the general signs someone should look out for that might signal apophysitis is going on?
Yeah, good question. Most often it presents with what we call an insidious onset of hip or groin pain. Insidious just means it develops gradually, sort of creeps up on you, not usually from one specific sudden event. That can make it tricky to catch early on. Initially, the pain might only happen during physical activity, running, jumping, kicking, twisting, shooting a ball, that kind of thing. But if it's not addressed, it can progress to where there's discomfort even just at rest. Statistically, quite a few cases, maybe around 43%, seem to arise during training sessions. Competition accounts for about 21%, and even warm-up about 2.5%. Then on physical exam, what you'll typically find is that localized tenderness right over the affected spot, often with a bit of swelling, maybe some warmth too.
Okay. So we've got a pretty clear picture now of what apophysitis is, where it tends to show up, the symptoms. But the crucial next step, obviously, is once it is identified, what's the path forward? What's the recovery look like for these young athletes?
Right. So non-operative management, meaning no surgery, is really the first line treatment for pretty much all patients. This mainly involves relative rest. That means stopping the activities or sports that are aggravating the pain completely. We need to give it a chance to heal properly.
Okay. Relative rest.
Yes. And then we add supportive measures. Things like using ice packs, maybe some NSAIDs, non-steroidal anti-inflammatory drugs, and sometimes topical agents to help manage the pain and inflammation. Physical therapy then plays a really key role in the rehab process. The focus there is on restoring flexibility, building back strength, and correcting any underlying biomechanical issues. It's all geared towards supporting a safe return to activity. It's definitely a carefully phased approach. You can't rush it.
That sounds like a solid, sensible plan. And the big question for athletes and parents, what's the prognosis once they go through this? Is it a permanent setback, or can they get back to their sport fully?
Generally, the prognosis for athletes with apophysitis is excellent, really quite good. Most are able to return to play fully, provided they follow the appropriate conservative treatment plan. Now, there's limited evidence on very long-term outcomes years down the line, but complications are rare. They can happen, though. Things like an avulsion fracture, where the tendon actually pulls a small piece of bone off. Or in very rare cases, maybe an inability to return to sport at the same level. But that's usually if the condition wasn't managed properly, or if the return to activity was pushed way too soon. It really does make you pause, though, doesn't it? Makes you think about the immense pressure we sometimes put on young athletes, perhaps unknowingly, when their bodies are literally still under construction in such a delicate phase.
Yeah, absolutely. So just to recap the main points here, what we've really dug into with iliac apophysitis is that, yes, it's an overuse injury, but it's fundamentally tied to this unique vulnerability of growing bones, specifically that physeal plate, the growth plate, being significantly less resilient, 2 to 5 times less, which is huge, than the tissues around it. But the good news, the really important takeaway, is that conservative management works. Relative rest, targeted rehab, a gradual return. It's typically highly effective, and that leads to an excellent prognosis for most young athletes.
Exactly. And to reinforce that, recognizing that insidious, gradual onset of pain is crucial. Understanding those specific symptoms that help pinpoint the location. Remember, Sit-ups potentially triggering iliac crest pain, sprinting aggravating the ACEs, kicking motions for the AIS, little clues like that. And while x-rays might look normal, don't stop there if the suspicion is high. Imaging like MRI and ultrasound, they are really key for confirming the diagnosis and making sure the management is right. And yes, complications like avulsion fractures, while rare, they really underscore why proper management and not rushing back to play is just so important.
So given everything we've learned today about these specific vulnerabilities in growing bodies, but also the excellent prognosis when it's handled correctly, it leaves me with this thought for you listening. What does this deep dive into iliac apophysitis tell us about our broader responsibility, as coaches, as parents, or even just as informed individuals? Our responsibility to foster healthy, sustainable athletic development in young people, really prioritizing their long-term well-being over maybe those tempting short-term gains. Something to think about.